Good afternoon, everyone. I'm Ajay Agarwal. I'm the Clinical Director for the National Cancer Audit Collaborating Centre. This is the second of two webinars. We had the first one this morning. Essentially, we are reporting our State of the Nation reports, the key results and findings. We review the quality of care nationally across hospitals and alliances in the English and Wales NHS. We look across the pathway from diagnosis to treatment. We also look at the timeliness of care, any data issues that we might find, as well as staffing. And we'll present 4 sets of audits today. If we just go to the next slide. This morning, we had presentations from the National Prostate Cancer Audit, National Bowel Cancer Audit, Kidney Cancer Audit, Ovarian Cancer Audit, and the Non-Hodgkin's Lymphoma Audit. Each of these audits have a State of the Nation report where they report on between 8 to 10 key cancer indicators. Those are available on the website, as well as the summary report of 10 pages. The presentations will also be available online on our website very shortly, which you can see following this. There was also a panel discussion. This afternoon, next slide please, we have 4 audit presentations. So there are 2 breast cancer audits, one for primary breast cancer and metastatic breast cancer. After a 10-minute presentation, there'll be a short Q&A. Please do add your comments and questions in the Q&A chat. We will pick those up and I will pose those to each of the speakers. We'll have the pancreatic cancer audit and the oesophago-gastric cancer audit following that. And then we have a really esteemed panel. We have patient representatives from Leslie Goodburn from the pancreatic cancer audit, and then colleagues from Macmillan, the Royal College of Radiologists, NHS England, the Welsh Cancer Network, Health Quality Improvement Partnership, and the National Data Registration Service. So we really have a 360 on what these results mean and the implications. So with no further ado, I'm delighted to invite, as again, just reiterating around the Q&A, but delighted to invite Kieran Horgan, who is the clinical lead for the National Breast Cancer Audit. Please take it away, Kieran.
Many thanks, AJ, and thank you to everybody for the invitation to present data from the National Audit of Primary Breast Cancer. It's very much a team presentation, with particular thanks to Michelle Wang, our clinical fellow, for putting today's talk together. Next slide, please. Our cohort represents stage 0 to 3, excluding metastatic at diagnosis, for the 3 years 2020 to 2022, and it comprises a total of about 135,000 patients, so large numbers. Next slide, please. When we look initially at data completeness for invasive breast cancer on the y-axis, for a selection of items, with the England results on the left half of the screen and the Wales on the right, we can see that the returns on grade are high, and it is difficult to understand why returns on molecular markers such as ER and HER2, which are universally performed, are not also almost reaching 100%. Stage declaration requires separate clinician or MDT staff input, and though much improved from years gone by, has plateaued over recent years. It requires a renewed drive to identify where are the gaps. We recommend that each MDT has a specific nominated data lead. It may be that performance status recording is not sufficiently valued by clinicians, and attempts to increase the recording will not be rewarded. We have developed and published a SCARF index on frailty and fitness, and we can bring that about and calculate it from HES data. So we can also use it at individual level. We are therefore not entirely reliant on the performance status for that valuable information. Next slide, please. Triple diagnostic assessment, or TDA as is shortened, is where a clinical assessment, the necessary imaging and biopsy are all performed at a patient's initial consultation. It is highly valued by patients. It is the first quality standard for breast cancer by NICE, and was a singular distinction for breast cancer compared to other tumour sites. When we initially investigated what data was available, we were surprised that there was no single COSD item recording TDA. This was rectified in collaboration with Andy Murphy and colleagues in NDRS, but the uptake in use of this new code at unit level has been slow. The graph shown here represents an algorithm of TDA using the consultation date from the cancer waiting time data and the biopsy date from COSD to see if they coincide. The biopsy will only have been performed if the imaging has been completed. So if the consultation and biopsy were done at the same visit, then TDA has been achieved. The algorithm is reasonably robust. The range is wide, and there is anecdotal evidence that TDA is less frequently available in more recent years as a result of clinic capacity stresses due to large increases in the numbers of patient referrals. We recommend that TDA is supported, and if not being achieved, that units look into what the cause for that is. Next slide, please. When we're looking, if I can introduce you to the format of this slide, which is to illustrate when we're trying to move national results to those achieved at alliance and trust level. On the left, you can see the national graph as we showed previously. And on this slide, we're looking at two alliances, Kent and Medway and Surrey and Sussex, and their constituent trusts are identified in orange on the graph and detailed in the table on the right. It has been our experience that this identification greatly increases local interest in the data, and we hope will stimulate audit at trust level. We recognise that the algorithm ideally requires both the cancer waiting time consultation date and the COSD biopsy rate returned. For example, looking on the right, for Royal Surrey, 25% of patients were missing either the consultation date or the biopsy rate, so their 48% is out of a maximum of 75%. This is the type of information one acquires and becomes more knowledgeable about with increasing presentation of the data. However, if you look at East Sussex, only 7% were missing, meaning their 25% is out of an achievable 93%. We are trying to get unit buy-in so that the TDA COSD item is answered at the diagnostic MDT. Next slide, please. Breast reconstruction, and IBR stands for immediate breast reconstruction, is a highly valued surgical option by mastectomy patients, and its availability is strongly supported by breast cancer charities. The guidelines recommend mastectomy patients are offered reconstruction, but there is no data item for such an offer, and the operation codes for delayed reconstruction are very complex. So this illustrates how one approaches that type of difficulty. We have adopted immediate breast reconstruction at the time of mastectomy as a reliable, informative indicator to open a window on reconstructive performance, and we feel we can be confident in the data. The wide variation in immediate breast reconstruction across alliances in England is clearly illustrated on this map, looking at alliances. Next slide, please. As with the earlier slide, alliance and trust data is presented here, and we can look at immediate breast reconstruction rates at local level. The denominators are still large. The units are marked in orange on the national graph as previously, and the attributed units are where the breast cancer diagnosis is made, as that unit has the responsibility to provide satisfactory care, even if the operation was going to be performed elsewhere. IBR performance has been adopted by NHS England Treatment Variation Working Group as the breast cancer priority for this year. So again, a considerable spread, and even a considerable spread within local alliances. Next slide, please. Discussion on immediate breast reconstruction and trying to compare them can be sidetracked by questions as to whether such a procedure is always applicable if certain adjuvant treatments such as radiotherapy are involved, or if the patient is elderly. We have therefore analysed the results where the denominator is patients aged under 70 and they only have in situ or small invasive cancers, so they will not be complicated by any substantial adjuvant treatment. As one would expect, the national average of IBR is therefore increased, but the variation is even more marked and therefore may be more informative. We are stimulating interest in these data through collaboration with the Treatment Variation Working Group, with individual alliances at their regional meetings, and with the GIRFT visits to alliances, as well as national presentations. Next slide, please. Reoperation after breast conservation surgery is where the pathologist examines a wide local excision specimen of a breast cancer and deems they cannot confirm the margins are clear of cancer, and the MDT therefore decide another operation is required to remove further breast tissue. It is an outcome for the patient and provokes discussion on both surgical and radiological performance. The funnel plot shown here of trusts shows a national average of 16% of breast conservation surgery patients return for further surgery, with a range of 7 to 31%. This involves thousands of patients. We again have taken this on board and have presented it at national and at local and at alliance level. Next slide, please. And when you go to the alliance and trust data, you can see where they sit on the national screen, and also where amongst the alliances the performance varies considerably. The graph is risk adjusted. All GIRFT visits now require trusts to explore their reoperation rates. I think it's our experience in audit that often you have to have repeated presentation of items with explanation and exhortation before you can bring about change. So even though reoperation rates was last year's priority, we continue to stress its importance. Next slide, please. I'm sure this audience knows, but neoadjuvant chemotherapy is where, with operable breast cancer, chemotherapy is delivered prior to surgery, and guidelines promote its availability to downstage larger node-positive cancers and cancers where the molecular markers indicate adjuvant chemotherapy with or without anti-HER2 treatment would be given, usually after the surgery. This slide shows the national use of neoadjuvant chemotherapy for the most relevant patients according to their molecular markers and subdivided by age. We can see that there's greater use in younger patients, and this tails off as the patients get older, and we can look at the different tumor groupings and see that the presence of HER2 positivity is a strong determinant. Though NICE and professional guidelines suggest NACT has advantages and should be considered, there is no published accepted standard of what should be achieved. And this is something that we often come across when we have national data sets. Next slide, please. This funnel plot shows the variation in the use of neoadjuvant chemotherapy across units. And one can see it's not tightly related to the volume of cases seen in those units, where you might expect large volume units would have a more coherent and consistent practice. This item will be introduced into the quarterly dashboards from our audit once we are satisfied that the molecular markers will be reliably available on the rapid cancer registration data set. Next slide, please. This is the team who do all the work, and I am grateful for the opportunity this afternoon to have presented this data. Thank you.
Kieran, warm thanks for your presentation. There was an inquiry about data for Someone's Cancer Alliance, which we've referred them to review, but I had a couple of questions whilst we wait for further ones. So you mentioned around the assessment of frailty, how that's been developed within the audit. You also showed the neoadjuvant chemotherapy rates, and you showed it by age and molecular marker. Has there been any pattern associated with frailty, or do we see similarly when adjusting that there is a decrease associated more with age than anything else?
Yeah, very good question. We're looking more at that, AJ, to see, is there a group that, for example, neoadjuvant chemotherapy would not usually be considered in, or certainly not pushed. And therefore, like we did for the immediate breast reconstruction, we could construct graphs for the most relevant population to try and show what the variation was amongst them.
Thank you. And you brought up reoperation, and there are stark differences. What was also noticeable, maybe compared to other audits, is the number of breast cancer surgery units and that variation, and no obvious volume impact. But is there a ground for certain cases being centralized in breast cancer surgery? Is that a discussion ongoing, or other factors, whether it's the radiology or the actual surgery itself?
We haven't seen a volume relationship when we tried to look at reoperation rates. Now, that's tricky, obviously, because the lower volume units, you need a longer number of years before you can determine what is happening there. But it hasn't been strictly volume of cases related. So the case for centralization may well be that the knowledge needs to be shared amongst the trusts within an alliance, for example, as to why one trust seems to perform so much better. And we're conscious as well that we don't get an untoward consequence, that if we are driving reoperation rates very hard, we end up increasing mastectomy rates. Now, we've looked at breast conservation surgery rates and reoperation rates, and there's no relationship. It seems that the factors that will be involved will be very much within a trust.
Thank you. Just one final question from me. So you mentioned about immediate breast reconstruction being the sort of focus of quality improvement with the primary breast cancer audit, and that there's a focus on the cancer alliances in particular. Could you just provide a bit more information how that process will transpire going forward?
Okay, thank you. As in the presentation, we picked immediate breast reconstruction out of all of what happens in reconstruction, not because it is the gold standard or we're advocating it, but it is where we have the best data. And again, it's an item that can be shared across the whole spread of breast units, because every breast unit will perform mastectomies. When we then go to try and transmit that information, we are working through the alliances because it's the avenue we have. The Treatment Variation Working Group have told the alliances that this is a priority for this year, and we have had reasonable access so far for where we've had invitations and knowledge of alliance meetings. We're trying to gather together a list of contacts at alliance level to try and see that when they have meetings that we can attend where possible, but even prior to that, that we can offer data to back up their discussions as regards immediate breast reconstruction. And that's gone reasonably so far.
Thank you. One final question that's come in was regarding the neoadjuvant data, which has been very well received. There was a question as to whether this varied between stage or was adjusted for in the results that you presented.
We have confined ourselves to stage 2 and 3 in order not to dilute the figures by including lots of stage 1, which would not be pertinent perhaps to the discussion. And we hope to be able to risk adjust to a greater extent once our numbers increase. And it's an area we hope to go into in greater depth, particularly if we can manage to have it as a renewable item on the quarterly dashboards.
Thank you so much, Kieran. Thanks for answering all those questions. I will now invite Gemma Boyle, who's the Clinical Fellow for the National Audit of Metastatic Breast Cancer. Gemma, please join us.
Okay. Good afternoon, everyone. I'm Gemma Boyle. I currently work as a breast registrar in North West London, alongside my role as Senior Research Fellow on the breast audits. I'm going to be sharing the key findings and recommendations from the second annual report for the National Audit of Metastatic Breast Cancer, also known as NAOMI. Next slide, please. So within the audit, we categorise patients into two distinct groups, and I'm just going to spend a little bit of time explaining this as it is fundamental to how we report. At the top of the flowchart, you can see all patients who are newly diagnosed with breast cancer. If you go down the left side of the chart, the stage 0 to stage 3, or the unknowns at diagnosis, form our primary breast cancer cohort, who are reported in our sister audit that Prof. Horgan has just presented. There are two ways then that patients can be included within our de novo metastatic cohort. The first is that they follow the right-hand side of the flowchart and have stage 4 disease at presentation. The second is that they go down the left-hand side of the flowchart, but are then found to have distant metastatic disease within 6 months of their diagnosis. In this year's report, the de novo cohort was made up of around 10,000 patients who were diagnosed between 2020 and 2022. The second, more complex group is our recurrent metastatic cohort, and this includes patients who start by going down the left-hand side of the flowchart and are then later found to present with distant metastatic disease, which presents more than 6 months after their initial diagnosis. And in this year's report, this cohort consisted of around 13,000 patients. Next slide, please. The most significant challenge for NAOMI is that at present, cancer recurrence is not consistently or systematically recorded in routinely available national cancer data to enable us to use it. In the interim, we have developed an algorithm that uses diagnosis codes for metastatic breast cancer in inpatient hospital records in order to identify our recurrent cohort. This year, we revised and improved the algorithm we use to capture recurrent breast cancer. And importantly and positively, this has allowed us to make significant improvements with a doubling in the number of patients we were able to identify for the recurrent cohort. Next slide, please. So leading on from this, the first two recommendations from this year's report focus on data quality. And as I've just demonstrated, this is really important as it underpins the work we do, in particular, the identification of our recurrent metastatic cohort. The most crucial recommendation, therefore, from the report is to improve the recording of recurrence. This includes the type of breast cancer recurrence, i.e. whether it's local or distant, and importantly, must also include the date of the recurrence for the data to be meaningful. A huge amount of work has already gone into making this an actionable recommendation through collaboration with NDRS to produce this practical guide shown on the slide, which you can download from our website to help ensure that your MDTs are recording recurrence correctly and accurately through a new non-primary breast cancer record. Next, please. To build on this, our quality improvement intervention for NAOMI is focused on improving the recording of distant recurrence. And this slide demonstrates just some of the ways that we are actively striving to collaborate with breast units and wider groups, including NHS England and charities, to make improvements in the recurrence data. Next slide, please. Continuing with the theme of data completeness, this graph shows data completeness for key patient and tumour characteristics for the de novo cohort over time, for England on the left and Wales on the right. The aspiration for these data items is 90% data completeness, and straight away you can see that there is room for improvement across all of the data items. In particular, data completeness for performance status is poor. Across the different data items over time, data completeness for England remains fairly similar, whereas we can see small incremental improvements over time for Wales. This information is crucial in enabling us to understand which treatments patients might be offered. We ask that each breast MDT has somebody, preferably a clinician, that takes responsibility for ensuring the submission of complete high-quality data. We're also really keen to be active in understanding whether breast units are experiencing any specific difficulties in their ability to return their data. Next slide, please. The next recommendation relates to the discussion of de novo patients in the MDT within 30 days of diagnosis. Evidence suggests that patient outcomes are improved when care is directed by an MDT, with various national and international guidelines recommending MDT discussion for patients with metastatic disease. The green bars on the graph represent each of the 121 breast units in England and Wales, with the vertical axis showing the percentage of patients at that breast unit that were discussed in an MDT. The average for England and Wales was 59%, but we can see huge variation, with around 1 in 4 breast units discussing at least 80% of their patients in MDT, but 1 in 8 breast units discussing less than 30% of their patients. We encourage breast units to firstly ensure that all metastatic patients are being discussed in MDT, and secondly, to ensure that this discussion and, importantly, the date of this discussion are being recorded accurately, so that this is reflected within your results. Next slide, please. An area of increasing interest is the use of CDK4/6 inhibitors for ER-positive, HER2-negative metastatic disease. The addition of these drugs to endocrine therapy alone has been shown to improve survival outcomes. This indicator can only be reported for England at the moment. The graph shows the risk-adjusted percentages for people with de novo ER-positive, HER2-negative metastatic breast cancer. The horizontal axis is the number of eligible patients at each breast unit, and the vertical axis is the proportion identified as receiving CDK4/6 inhibitors within the first year of diagnosis. The red line indicates an average of 38% for England. Some of this variation may be explained by data quality, and we urge trusts where possible to check their data and feed back to us how reflective our results are. However, it's unlikely that data quality is the full explanation for this wide variation. Even after risk adjustment, we can see that there is significant variation in the proportion of people receiving CDK4/6 inhibitors, with some breast units giving them to over half of their patients and other breast units giving them to less than 10% of their patients. If breast units do identify that their rates are low, then we would ask them to explore possible reasons for this and identify any opportunities for potential improvements. Next slide, please. Our final recommendation relates to 30-day mortality following chemotherapy for the de novo cohort on the left and the recurrent cohort on the right. The horizontal axis is the number of people receiving chemotherapy, and the vertical axis is the proportion who die within 30 days of a chemotherapy cycle. You can see that this is higher for the recurrent cohort compared to the de novo. However, despite risk adjustment, there is wide variation for both cohorts. We would again prompt breast units to look at their individual results, and those units particularly who fall outside of the dashed lines on the graphs, review their outcomes and local prescribing practices to ensure appropriate consideration of benefits versus risk. In the future, we hope to make this performance indicator more granular in terms of looking at this in relation to line of treatment to provide greater context about the appropriateness of treatment. Next slide, please. Please do read our full report and check your own breast units data using our data tables. Next, please. There is also a patient version of the report available. Next, please. If there is one key message that we'd like you to take away from this, it would be to ensure that your MDT is recording patients with breast cancer recurrence accurately, including the date of recurrence. Please do download and distribute the recurrence guide that I showed you earlier to help with this. Next slide, please. Next. So this is a team effort, including all of the people on this slide, and we of course thank our wider AAC and Patient Public Involvement Forum for their valuable contributions. Next slide, please. We're always very happy and value your feedback and interaction with the audit. Thank you very much for listening, and happy to take any questions.
Thank you, Gemma. Excellent presentation. Huge amount of work that's been done. Some questions are coming through, but just to kick us off, I'd be really interested if you could enlighten us a bit more about the 30-day mortality figures that you have. You obviously see the difference between primary, metastatic and recurrent, just how that's been developed, because I know there are also other data sets which produce that information, what can be done, what are the drivers, because there is quite a huge amount of variation, something that is avoidable in many circumstances.
Yeah, so at the moment we can only report this metric for England, and that's because Wales only provide the first cycle of chemotherapy information. So there's issues with sort of high outliers and possibly with low outliers, so outside of the dashed lines that I showed, and that variation could reflect a number of things, including differences in the selection of patients or the appropriateness of treatment, so under or over treatment. Higher rates might be reflective of things like inappropriate regimen use, dosing issues, issues with monitoring, or a failure to recognise or address toxicity promptly. And there might also be wider differences in terms of access to acute oncology services or specialist out of hours advice. And then, of course, there's the issue of patient choice. Conversely, the lower rates potentially could indicate risk-averse behaviours. So it's certainly an area that we want to explore more. And as I mentioned in the presentation, we think that better understanding of those rates in relation to lines of treatment might help to start unpick that a little bit more with regards to appropriateness.
Thank you, Gemma. It's an important one to unpack, especially given what you've seen. There have been a couple of questions regarding data. Obviously, that's been presented today, particularly around performance status, which all the audits require and is important. You've used the frailty index and comorbidities that are well established, but there's also another question around receptor status, for instance. Any advice as to how that can be improved? That's a direct question. Obviously, it's part of improving more widely inputs into the data sets that go to the National Cancer Registration Service. But any thoughts from your perspective how this could be done in a systematic manner?
So I think the key thing is, as we mentioned, about making somebody in the MDT responsible for the quality of your data. Every patient should have ER and HER2 status recorded, so it's just getting that information into the correct place during the MDT so that that can then be uploaded to the relevant place. So I think, yeah, having a person nominated as your data quality lead who will take responsibility for that would be really helpful.
Thanks, Gemma. There may be someone on the team who responds specifically in addition to Talvinder and Carl. Claire's got an interesting question and probably relates to where the audits will probably be developing, but has asked whether there's a breakdown at all of where the metastases are. Are they, visceral organs, bone, or lymph node metastases? Is there any work that's been done to look at that or focus, or where that can be derived, that information?
I might have to double check with our methodologist. I know that we do capture that information. I'm not sure that we're presenting it anywhere at the moment. I'm not sure about the quality of that data, but it is on the recurrence capture form that I showed you. So it is one of the boxes that MDT should be completing.
Yeah, and also I think if they're having radiotherapy to any of those sites, that's recorded within the radiotherapy data set. And just more broadly, there is some wider work going on the audits to use the linked data sets to look at patterns of recurrence. And part of that is trying to establish where that recurrence is with the available coding, but that's ongoing. So we can respond more to that. There's a question from Slater, probably the last question from this session. So repeat biopsy of metastatic disease has been mentioned previously as one of the indicators to explore. Is it still the case? Are you looking to see whether repeat biopsies are being done for recurrent cases? And will that be, if it is measured, what data set could that be in potentially?
Yeah, so we do have that as a performance indicator. At the moment, it wasn't in one of our key recommendations, but there is further information on that in the full report, and also in our data tables.
Thanks, Gemma. You've made time. Thank you for fabulous presentation. Thank you to all the team. Please do look at the website for a deep dive on that information. So next up, we have the National Pancreatic Cancer Audit. Delighted to introduce Min-Hei Park, who's the Senior Methodologist for the National Pancreatic Cancer Audit, and some very interesting data to report and findings that matter across the NHS. Thank you.
Thanks, Ajay. Hi, yes, I'm Min-Hei, and I'm a methodologist on the National Pancreatic Cancer Audit. Today, I'm obviously presenting on behalf of the whole audit team, and I'm going to highlight some of the key findings and recommendations from our most recent State of the Nation report. Next slide, please. In this year's report, we focused on the care received by people diagnosed with exocrine pancreatic tumours over 2-year periods in England and Wales. So we report diagnosis over 2 years to ensure we include sufficient numbers of people to be able to report on subgroups, and also to report the results of individual providers. So you can see on this slide that we included over 17,000 people diagnosed in England and around 900 diagnosed in Wales. The audit reports 10 performance indicators, which are listed here. And these were selected with the intention to try to cover the patient pathway from all the way from kind of early diagnostic imaging and MDT discussion through to treatments, supportive care, and also looking at survival outcomes. So in today's presentation, I'll focus on just a few of these indicators, kind of highlighting the areas of care where we've identified where there may be need for improvement or are a priority area in terms of the audit's quality improvement goals. Next slide, please. So the first indicator we wanted to focus on is median time from urgent GP referral to disease-targeted treatment. So when we refer to disease-targeted treatments in the audit, we mean we include surgery, systemic anti-cancer therapies, and radiotherapy. So in this table, we can see that in England, the median time to treatment was 78 days, so around 2.5 months. And another way of expressing a median time is that half of people in this group waited longer than 2.5 months from urgent GP referral to receive disease-targeted treatment. In Wales, the median waits were longer, with half of people waiting more than 3 months from referral to the beginning of treatment. Next slide, please. So these figures kind of indicate to us that some people are waiting too long to receive their treatment, but we also observed wide variation in the median wait times across NHS trusts in England and local health boards in Wales. We can see that median wait times in some organisations were over 100 days, so at the upper end of that range. Next slide, please. So these findings led to the audit making a recommendation for pancreatic service providers to map their diagnostic pathways and to review the processes against HPV cancer pathway guidance. Notably in NHS England, that's the HPV best practice time to pathway, and in Wales, that would be the National Optimal Pathway for Pancreatic Cancer. We also recommended that providers should consider conducting case reviews to understand their pathway challenges and to identify areas of good practice in their local areas. Next slide, please. So next we're going to look at the percentage of people diagnosed with non-metastatic cancer who received disease-targeted treatment. And again, when we refer to disease-targeted treatment, we're talking about surgery, SACT, and radiotherapy. Overall, the rates of treatment were not high, even in this non-metastatic group. Only 57% in England and 51% in Wales received disease-targeted treatment. And when we narrowed our focus even further to those who had a good performance status at diagnosis, so that's a performance status of 0 to 2, only around 2/3 of these people received treatment. And I think by now you're possibly very familiar with funnel plots, but this shows, this particular funnel plot shows the variation in treatment rates across trusts in England. And we can see that these range from as low as 15% in the trusts with the lowest rates of treatment to almost 90% in those with the highest rates of treatment. Next slide, please. And so based on these findings, we recommend that providers should adopt a personalised approach to optimising patients' fitness, nutrition and medication to prevent deconditioning before treatment can begin. And we suggest that this might include prehab, rehabilitation, engagement with oncogeriatric services, dietetic support, and also early access to supportive care. We also recommended that providers should review those cases where people have survived over 3 months but didn't receive any disease-targeted treatment to try and understand the reasons or the decisions not to treat. Next slide, please. So kind of building further on this, increasing rates of treatment has been identified as a priority area by the audit. And we've developed a quality improvement intervention with the aim of supporting services to improve treatment rates. And more specifically, we'll be providing bespoke feedback to support cancer alliances to identify and work with the trusts within their alliance who have low rates of treatment and to identify areas of good practice. Next slide, please. So yes, the next area of focus is the use of pancreatic enzyme replacement therapy, also known as PERT. So I think for those of you who aren't familiar with it, PERT is an important therapy that improves digestion and nutritional status in people with pancreatic cancer. And this, we found that only 54% of people diagnosed in England had a primary care prescription for PERT. And again, as this funnel plot shows, there was wide variation in rates across trusts, from as low as 18% to as high as 79%. Next slide, please. So we recommended that providers should implement protocols to ensure that all people diagnosed with pancreatic cancer are assessed for eligibility for PERT at the earliest opportunity. Next slide, please. And I think it's important to highlight the survival outcomes for people with pancreatic cancer. Unfortunately, pancreatic cancer remains among the least survivable of the major cancers. And in both England and Wales, over 1/5 of patients died within 30 days of their diagnosis, while over 3/4 died within a year. Next slide, please. And finally, I thought I'd briefly kind of have a look at some of the changes over time in our indicators. So in that first row, bar chart there, we can see that whilst we've identified that the rates of disease-targeted treatment for pancreatic cancer are low, there is an indication that there's been perhaps a small increase in the most recent 2 years for which we have data. So the audit will be able to monitor if this is a longer-term trend, and we'll also be able to evaluate whether our QI intervention kind of might accelerate improvements in this area. Kind of related to this, when we look at the second bar, so we can see that when we look at the percentage of people undergoing surgery who received neoadjuvant chemotherapy or radiotherapy, the rates of this have doubled over the 5 years for which we have data. And finally, the percentage of people who are prescribed PERT in primary care has increased over the period for which we have data, but we note that this there has been a national shortage of PERT since the middle of last year, and this is ongoing. So in future audit cycles, we'll be able to describe and monitor the impact of this shortage on prescribing rates. Next slide, please. So yes, just all that remains to say, obviously I'm here on behalf of the wider project team, who you can see here on this slide, and let me say thank you for listening.
Thank you, Minhei. As I think reflected last year, 1 in 4 patients diagnosed with pancreatic cancer, only 1 in 4 survive for 12 months is clearly not good enough. There's a lot of information that you've provided, which may provide some suggestions of where we can improve to achieve a better outcome or target. There's just some reflections in the Q&A about some of the data that you've presented. So one of them was around to what extent those ranges for treatment, for a disease modifying treatment in stage 1 to 3, those ranges change if you were stage 1 or stage 2 or stage 3. Is it very much skewed towards stage 1, a much higher rate than stage 2 or 3, or is the data adjusted in what you present? It would be good to hear a bit more.
Yeah, no, that's a really good question. And so these are our unadjusted rates, obviously looking just at the stages 1 to 3. I think there is a pattern by stage, but it's not perhaps as strong as we might expect. And we think that may be in part due to the fact that staging information is so we have some issues with the completeness of stage information, but also I think because of the aggressive and rapidly, the fact that pancreatic cancer can progress quite rapidly. Obviously, this is stage at diagnosis, and I think we've kind of alluded to some potential pathway issues and as well, which may lead to delays that can then mean that someone is no longer eligible for treatment when perhaps they could have been at diagnosis. So there is, but I don't have the figures to hand. Unfortunately, we did look by stage as well. There is a trend, as you might expect, with more treatment in the less advanced cancers.
I suppose on that basis, if we looked across alliances, do you think there's much difference in, say, the proportion of the 1 to 3 diagnosed with stage 3 in particular alliances? I mean, we've seen it for pancreatic and other audits, that there does seem to be a geographical distribution, as that's probably one half of the equation. What are your thoughts on that?
So I think that there is some variation across units. I think some of that is very hot. And some of that is also down to the kind of hub and spoke nature of the services. As you can imagine, that people who are diagnosed at a hub may differ in some ways to people diagnosed at a spoke hospital, and simultaneously the rates of treatment will differ. I'm trying to think if we have looked at regional differences in stage at diagnosis. Oh, we do have that information in our data tables. I couldn't say off the top of my head what the extent of that. Yeah.
But there, I mean, there is clearly enough signal by the variety, even if it was explained by a slight stage distribution, we wouldn't necessarily expect it to be systematically so. I think you're right, the hub and spoke, we know that there's a difference in primary stent rate, differences in primary treatment between a hub and a spoke. If you're diagnosed in a hub, more likely to get a disease modifying therapy when we've done a deeper dive, and I think that geographical variation will be important, but equally this data is probably the most urgent to look at locally, I think, from a alliance or trust level. So there's just on that, or just more generally, is there any mention or coding for a previous history of pancreatitis prior to cancer diagnosis? That's come in from Claire Foster. Are we able to pick that up, or is that something that we've assessed or been mentioned?
That is a very good question. I think that is potentially, if it's coded well, for example, in HES, if we had sufficient look back in HES, and we currently have about 2 years of look back, I wonder if that's sufficient to look at diagnostic codes of pancreatitis. But yeah, we haven't looked at that, but that is a good suggestion.
Certainly for severe cases or even moderate cases would result in a hospital admission. So I think that is something we can look at. So thank you for that comment. I think final minute, there have not been any further questions just around your quality improvement initiative and the focus on that. Would you just say a bit more about it?
Yes, so I suppose the aim of the audit is to try and support cancer alliances to improve rates of disease target treatment in those trusts where the rates might be lower than might be on the lower end of that range. So the actual intervention itself will take the form of a bespoke feedback letter, which will be sent to contacts at the alliances, kind of really highlighting, you know, these trusts within your alliance maybe have rates of treatment lower than, you know, the national average or lower than the target, and conversely also highlighting areas where the rates of treatment might be higher than average. And so we will also be putting together some, I suppose, practical tips. We'll be collecting information from alliances. Also, you know, it'll be a two-way kind of intervention, if you like, with getting feedback on what might have worked in certain areas, these areas of good practice, why are some trusts able to achieve much higher rates of treatment than others, and using that as the basis to kind of support those areas where there might be potential issues.
Thanks so much, Minhei. I think I've grilled you enough. There'll be some further questions, I'm sure, through the Q&A, but thank you to you and your team for that presentation and the findings, which are available on the website. So delighted to introduce Olivia O'Connor, who's going to be speaking on behalf of the National Oesophago-Gastric Cancer Audit. Olivia, the floor is yours.
Thank you. Good afternoon, everybody. I'm Olivia O'Connor. I'm a clinical fellow for the National Oesophago-Gastric Cancer Audit. I'll be presenting the key findings and recommendations from the State of the Nation report, which summarises outcomes for patients diagnosed between January 2022 and December 2023 with esophageal or gastric cancer. Today I'll highlight what the data tells us about where care is improving and where challenges persist. Next slide, please. So NOGCRA evaluates the quality of care for people diagnosed with esophageal or gastric cancer across the NHS in England and Wales. Our aims are to support clinicians, cancer alliances, commissioners and policymakers to identify unwarranted variation and drive improvement in outcomes. We produce an annual State of the Nation report which integrates audit indicators across the entire patient pathway, from diagnosis through to treatment and survival. We also publish quarterly reports through an online data dashboard where providers can track their performance at regular intervals and monitor progress over time. Next slide, please. Around 1 in 5 patients are diagnosed with esophageal or gastric cancer following an emergency hospital admission, and over 1/3 present with stage 4 disease. These rates are highest among people with gastric cancer, reflecting the non-specific and often subtle symptoms associated with the disease. Emergency presentation is also strongly linked to older age and socioeconomic deprivation. For example, 29% of patients aged over 80 were diagnosed as emergencies, compared to 17% of those aged 60 to 69. Similarly, 24% of patients living in the most deprived areas were diagnosed via emergency admission, compared with 18% in the least deprived. We have seen no improvement in emergency or late-stage diagnoses over the past 5 years, and there remains considerable variation. Across 118 NHS trusts in England, the median emergency diagnosis rate was 21%, with an interquartile range of 18 to 24%. These findings underscore the urgent need to strengthen early diagnosis initiatives, optimise referral pathways, and raise public awareness of OG cancer symptoms, particularly for gastric cancer, where early stage detection remains the exception rather than the norm. Next slide, please. Around 1 in 5 patients are diagnosed. In the State of the Nation report, we've updated how timelines through the diagnostic and staging pathway are calculated, ensuring that our figures now align with the metrics published by Cancer Waiting Times and complement these metrics. Our focus is on the part of the pathway most relevant to secondary care services, from diagnosis of disease-targeted treatment. For most patients, diagnosis is confirmed by upper GI endoscopy with biopsy. So we have measured the interval from this procedure to the first disease-targeted treatment. Across England, the median time from diagnostic endoscopy to start of treatment was 64 days, while in Wales it was even longer at 72 days. But there is wide variation between providers, with an interquartile range of 48 to 84 days in England and 51 days to 104 days in Wales. Waits were longest for patients receiving curative treatment, particularly those undergoing surgical resection without neoadjuvant therapy. These findings highlight opportunities to streamline diagnostic and MDT pathways, especially in complex multi-specialty centres. Reducing these delays could improve both patient experience and clinical outcome, and this forms the focus of our forthcoming National Quality Improvement Intervention, which I'll discuss shortly. Next slide, please. So among the 68% of patients for whom CNS data were recorded, the majority did have contact with a clinical nurse specialist. However, access was lower among those presenting as emergencies and among patients who died within 90 days of diagnosis. Importantly, 1/3 of patients had no CNS data recorded at all, and no CNS data were reported for Wales. This means we cannot be confident that all patients are receiving this vital form of support. And it really does matter. Patients who are supported by a CNS are more likely to understand their diagnosis, participate in shared decision-making, and report better overall experience of care. Ensuring timely CNS involvement, ideally within 72 hours of diagnosis, should therefore remain a key service priority across all OG cancer pathways. Next slide, please. Turning to outcomes. No surgical survival outliers were identified during this reporting period. This provides strong reassurance about the safety and consistency of esophago-gastric cancer surgery across England and Wales. Among patients diagnosed with stage 1 to 3 disease, between 45 and 59% received curative treatment. However, there remains some regional variation in access to surgery and multimodal therapy. 1-year survival after curative surgery has remained stable, reflecting the benefits of continued centralisation, refinement of perioperative care, and robust multidisciplinary team working across specialist OG cancer centres. Next slide, please. So among patients receiving palliative systemic anti-cancer therapy, around 55% completed at least 4 cycles of NICE recommended treatment. We recommend that all centres adopt structured fitness assessments, such as a clinical frailty scale, to support decision-making. These measures help ensure that patients are appropriately selected for treatment, balancing potential benefits with the risks of toxicity. While palliative SACT can offer symptom relief and modest survival benefits, it's not without significant side effects. For patients approaching the end of their life, best supportive care may often be more appropriate and better aligned with the person's values, goals, and preferences for quality of life. Next slide, please. Bringing these findings together, the State of the Nation report makes 5 key recommendations for improving outcomes and patient experience. First, to improve early diagnosis by increasing public awareness of symptoms, supporting timely referral, and expanding diagnostic capacity. Second, to streamline diagnostic and decision-making pathways, reducing unnecessary delays between endoscopy, staging, and treatment planning. Third, to improve patient selection for palliative systemic therapy, ensuring treatment decisions are grounded in an objective assessment of fitness and aligned with patient preferences. And fourth, to ensure timely access to a clinical nurse specialist for every patient, ideally within 72 hours of diagnosis, as this support is integral to high-quality care. And finally, to improve pathology data completeness, which remains essential for accurate reporting and benchmarking of key surgical quality indicators. Next slide, please. We continue to see high rates of late-stage diagnosis and prolonged waits for treatment, both which limit opportunities for curative care and adversely affect patient experience. Data completeness, particularly for pathology, also remain a key challenge, restricting our ability to benchmark surgical performance with full confidence. This autumn, NATCAN is launching a new National Quality Improvement Initiative focused on reducing the time from diagnostic endoscopy to start of treatment. As already mentioned, the median wait time in England is 64 days, with an interquartile range of 49 to 84 days, highlighting the wide variation between NHS trusts. The intervention has two components. Firstly, we will provide enhanced bespoke feedback directly to Cancer Alliances, including a detailed breakdown of trust level results. Secondly, from next January, we will begin publishing quarterly alliance and trust level data on waiting times through the NATCAN online dashboards, and this will enhance support for local data monitoring. Next slide, please. So thank you very much for your attention. This work would not be possible without the hard work and commitment from the whole team and the wider OG community. Our collective goal is to ensure that every patient diagnosed with esophageal or gastric cancer receives the highest standard of care wherever they are treated in the country. And I'm happy to take any questions. Thank you.
Thank you very much, Olivia, and well done for getting through some of the IT challenges both before and during. So excellent. And I think, as you said, everything's available on the website. A recording of this will also be available, but a huge amount of data across a wide spectrum. I think really harnessing sort of tri-modality care and all the different features of that. Whilst we're waiting for some questions in the chat, I just wanted to reflect on the systemic therapy, and I think they're probably interlinked to some degree around, clinical nurse specialist support, less for those presenting as emergencies, those with more likely to die with 90 days. But then you do have people starting the treatment and then not completing. Is there something missing in the pathway which means that patients aren't completing it, or is this selection of patients or ongoing management? What are the thoughts? Because there is a large variety of variation and outliers when we looked at it.
Yes, I think that's a really good question. The completion of more than 4 cycles of SACT is used as a proxy measure of treatment tolerance and appropriate patient selection. So there could be a variety of reasons for low completion. That might be that there is a degree of over-treatment of patients with poor performance status or advanced frailty. It may be inadequate sort of pre-treatment assessment. So that could be comorbidity or nutritional status. It may be that toxicity is leading to early discontinuation and variation in service delivery, so chemotherapy dosing, access to oncology review or supportive care. From our results, we also know that just over 4% of patients die within 30 days of starting their SACT. So again, this would suggest that perhaps it's not always the most appropriate treatment option for those patients. And some of the actions that we've suggested to improve completion of chemotherapy and outcomes would be, as I mentioned, a structured fitness assessment. So using validated scoring systems like the Clinical Frailty Scale to evaluate somebody's suitability for tolerating palliative chemotherapy. Comprehensive pre-treatment counselling, and I think this is where the role of the CNS comes in really importantly, to ensure that patients understand potential benefits, toxicities, likely outcomes, and make sure they're supported in informed decision making. There's also the review of high-risk cases and those patients where it is borderline, if they're suitable, to have the discussion with them about alternative treatments like best supportive care. And we've also recommended that in cases of early deaths following SACT, that there should be local M&M meetings to review all patients who die within 30 days of starting SACT. So I think that's
Yeah, no, Olivia, that's a very rich and granular answer. I think you've layered it correctly. I mean, you know, the number of clinics using a comprehensive geriatric assessment when they know that they exist is very small. Oncogeriatric support, the importance of the clinical nurse specialist, appraisal and evaluation of patients during treatment, and ensuring that they're aware of the best and worst case of the treatment itself. So I think actually there are a number of areas that can be improved quality-wise, and I think as that data matures, we'll get a better understanding of that. So thank you very much. We've finished on time with regards to the presentation, so I'll let you go so that we can move on to the panel discussion. But thank you very much, and the team. So now for the panel discussion. There is a seventh member, not just the famous six as such. So if we could get our panel members through. So we have Martine Baum, Dan Cariad, Tom Crosby, Danny Keenan, Richard Simcock, Nikki Thorpe, Leslie Goodburn. So what I'm going to do, if we just take off the slide, is I'm going to go around. I'm going to just get you to introduce yourself so you get used to talking, because you're going to carry on doing that for me for the next 20 plus minutes. So if I just go around my screen, if Richard, do you want to just kick off, please?
Yeah, hello everyone. I'm Richard Simcock. I'm a clinical oncologist treating breast cancer down in Sussex, which NATCAN have told me is the busiest breast unit in England and Wales. So that's why I'm in clinic right now. But I'm also Chief Medical Officer at Macmillan Cancer Support, who obviously have an interest in nursing support for patients and in unwarranted treatment variation.
Tom, do you mind going next?
Yeah, because that's me. So Tom Crosby, Clinical Director for Cancer Services in Wales. I'm an OG clinical oncologist and involved obviously in the NOGA audit, and I'm sure it'll be reflected in the answers that we have or the discussions that we have shortly. Really welcome, you know, the richness of the data that we've heard presented today, demonstrating variation, some of which will reflect data quality, some of which will reflect service quality. But I don't think we can hide behind either of those as excuses to why we have that variation. So look forward to exploring that. Thanks, AJ.
Thank you, Tom. I've just gone off screen because there's a maximum of 7, and I think you're all better looking than me. So I'll move on to the left as such. Then, Nikki, do you mind going next? Just introducing yourself.
So thank you very much, and thank you for inviting me to join the panel. I'm Nikki Thorpe. I'm a clinical oncologist now working at the Proton Centre, just treating children at the Christie Hospital. However, in previous life, I have been a breast clinical oncologist for many years in Liverpool, and also spent some time treating patients with upper GI cancer. So really interested to hear the data today. And I'm here representing the Royal College of Radiologists as Vice President for Clinical Oncology. Thank you for having me.
Thank you. Can I have Leslie? Do you mind just introducing yourself, please? Thank you for joining.
Of course. So I'm Leslie Goodburn. I'm chair of the Public and Patient Involvement Group working on the pancreatic cancer audit. So involved from a patient and public point of view.
Thank you for joining us. Martine, can you go introduce yourself?
Hi everyone, my name's Martine Baum. I'm Head of Data Projects for the National Disease Registration Service, or NDRS for short. We lead on the bulk of the curation of the routine cancer data that flow through the NHS, and we make that data available to NATCAN for their audits. I head up a team that does a number of things, but of particular relevance to today's call is the fact that we lead on data improvement for the National Disease Registration Service, so working with trusts and supporting them with their data submissions for the routine cancer data flows.
Thank you. Dan?
Danny Keenan. Sorry, Dan. Sorry, go ahead.
Sorry,
too many Dans. And
yes.
I will go first. I'm Dan Cariad. I'm Deputy Director of the NHS Cancer Programme, and I'm here because we both commissioned via Danny and HQIP 5 of the 10 audits using our service transformation money, but we also run the treatment variation programme through the Cancer Alliances as part of the National Cancer Programme, where we try and pick up particular recommendations focused on variation and access to the best treatment from the suite of audits, and really push for reduction in variation and implementation of some of the recommendations from the audits themselves.
Thank you. And Danny?
And so certainly just from Wales, Dan, it's a rather lovely name you have. I'm sure you've been told.
There's a story behind it which I will not go into now, but another time.
Danny, Keenan,
Okay,
that is,
well,
please.
I'm originally a bit more west of Wales. There we are. So I'm Danny Keenan, Medical Director of HQIP, who commissioned for the NHS in England the audit programme. I'm seconded in this role from Manchester University Hospitals, and I masquerade, particularly in a group like this, because my DNA is that of a cardiothoracic surgeon, retired now, but very happy to join you. And these have been great presentations, really fantastic, as the morning was as well.
No, I agree. I think they're very rich discussions, a huge amount of data, but actually drilling into that and improving is probably the next stage. And I want to start with Leslie, if I may, just to have your reflections. Obviously, you're working with the pancreatic cancer audit. Maybe you want to reflect on that audit or some of the other data as to, where do we go next? What do we need to do better?
Yeah, I think my reflections are that the involvement of people with lived experience, and often for pancreatic cancer, because of the statistics, it isn't always patients, it's people like myself who've been affected by pancreatic cancer. So my husband Seth died 11 years ago from pancreatic cancer, 33 days after diagnosis. Since then, been doing lots of work to raise awareness, campaign for more research, improve end-of-life care, and think about the psychosocial elements that need to support people. So I think having patients and people who've supported patients involved in the audit just brings a very different dimension. It questions the data in a way that people who are involved in healthcare and involved in data don't always question in the same way. Why? What's the impact? I think particularly for pancreatic cancer, there's lots going on around research. I think there are links to the Getting It Right First Time programme that's going on with pancreatic cancer. Some of the data that's coming out of that kind of lines up with what's coming from the audit, the work of Pancreatic Cancer UK and the Optimal Care Pathway. I think there are lots of things going on. So I think it's about leveraging the data that comes out of the audit, finding where there are links and making sure we do the best that we possibly can for patients. And I would assume that would be the same for all the different kinds of cancers that you do in the audits, finding where there are synergies, where there's work that can come together and make those improvements for patients and the people who look after them.
Lots of nods, Leslie. We couldn't agree more. I think also within NATCAN, for each of the audits, we've got a PPI chair and a PPI group, which involves people with lived experience or been carers of people who've had and lived with cancer. So we thank you for that reflection. And I think particularly with the pancreatic cancer and the esophageal cancer, the data seems to unpick that actually the right choice of selection of treatment at the right time to the right person is incredibly important, and that dialogue and the support around that is hugely important. I'm going to go to Richard next. Speaking of supportive care and looking at this treatment variation, what are your reflections, Richard?
Well, just hats off to the teams for producing such granular data, and it to see the dashboards in their current form is really helpful, so that we can start to make comparisons across units. It does allow you to have more granular conversations about performance, and when I think about when you hold a mirror up about data, but I don't know about the Kubler-Ross stages of grief. I mean, the 3 stages of, I think, are denialism, exceptionalism, and fatalism. The first people deny that, oh, this isn't true, this data. So why does a very famous cancer hospital just 50 miles north of where I'm sitting report less than 2% of people seeing a clinical nurse specialist? So I'd want to talk to them about that. Then there's the exceptionalism. Well, it's special where we are. We're different to everybody else. And then there's the fatalism of that, well, we can't do anything about it. And I think having this data allows us to try and start to deconstruct that. And Kieran, in his presentation, did something I'm sure quite strategic but very clever, which was to show data across an alliance footprint or an ICB footprint. And that feels to me like the appropriate footprint to start sharing data together so that we can start making differences. Because if I start comparing myself with Nicky's trust up in the Christie, there might be very significant regional differences that might start to explain that. But if I'm comparing my performance with a trust that's just 20 miles up the road, that exceptionalism starts to not carry. So this degree of granularity, I think, is really helpful in us starting to have some really useful, constructive conversations.
Yeah, I think it's that awareness of holding a mirror to where we're at, but also that pushback is much cultural, isn't it? We don't do any wrong. We've got all the latest treatments, and I think that can often be the bedrock of ignorance in this regard. Tom, if I can just ask you to reflect on, we report in England and Wales where you see the data, both the sort of country-wide comparison, but also what are the key differences and areas of improvement that are required?
Yeah, I'd be delighted to do that. I mean, I think we are in an interesting place, and I'm sure all regions, alliances, and the size of Wales, with 3.2 million people, so size of a reasonable alliance in England, but no bigger, and probably to be more compared with the northwest or the northeast of England, in terms of outcomes and performance. But we're also going through a period of change in terms of our informatics and intelligence that we're collecting in Wales. I think the clinical community have fought very hard to maintain our links with England and Wales data, to say that it's great that we can benchmark against other areas and regions and between England and Wales. So one of the things is, AJ, I'm not sure that who's on the call, to be honest, the other 150 people. So just in case there might be some of my political masters on the call, I'm just going to be a bit careful what I say, but assuming they're not, clinically, we've made the case very strongly that we value this as a clinical community, and I think we have really benefited from participation in the audits. So that's good. We're going through a transition phase. About 3 or 4 years, we had our own bespoke cancer informatics system. It was used for cancer waiting times, for cancer registration, for everything. And our case ascertainment was 99.9% because you had to register every patient, but it wasn't able to modify. It wasn't able to adapt to the information and intelligence that was required and clinically indicated for national and clinical audits. So we've gone through a big period of change, and we're still going through that at the moment. And I think the data quality coming from Wales for the next 18 months is still going to be challenged, but we're very, very keen to maintain our links and part of this national audit initiative. So every time we look at the data, it'll be, is it service quality? Is it data quality, as I said earlier? And we need to challenge ourselves on what either of those approaches. I would also say, AJ, that we shouldn't necessarily need to wait for the 3 standard deviations or whatever in terms of outlier status. If we're 10% bottom or top, let's look at that. Let's just ask ourselves the question, why are we there in that table? Is it data quality? Is it service quality? Minhei and others in the NOGA audit that I've been part of for quite a few years will know that I'm very, very keen on the cancer pathways, because I do think, despite myself being tertiary Tom and a clinical oncologist at the end of the pathway, I do know that in the end it's all about prevention, early diagnosis, getting people into the pathways and getting them through that diagnostic and subsequent treatment phases. So I think that's not just a question of us going to clinicians talking about the biology of the disease. It's more about the capacity of the system. I think it's a barometer of the health of the system when we look at those cancer pathways. And I think, as Minhei said earlier, to know that 50% of people, or I think it might have been Olivia actually, but 50% of people are waiting longer than that 70 or 100 days. That's wrong. And I think what we've tried to do is try to fine-tune the measurements that we give to those QPIs to be even better than the, dare I say, NHS England cancer waiting time data. Just because I think from the time you've seen a tumour at an endoscopy, for instance, for upper GI cancer, to the time of treatment is a really hardcore endpoint, and it shouldn't be as long as it is. So I guess a question then back to you, AJ, then would be just at the end of can we link in other data sets? I'm not sure that we're linking in our radiotherapy and SAC data sets, but that will come, I promise you, in the next year or so. Keep pushing as you are. How about the patient experience? Is there possibility of linking that data set into the data sets we have?
So all good questions. I just want to actually take it back to your original point about it's not about just waiting for the outlier process. There is a big variation, and we have each a responsibility to look at that data and take it at face value. I think we would be making a grave error to suggest that it's immediately data, and even if it's data, many of the institutions that we work in do not submit data adequately, no matter what their brand is and what their reputation. So I think first and foremost, do not expect that if you think you're in a reputable brand or hospital, that's going to be achieving the excellence that you want. It's not just about the individual, it's about multidisciplinary care. I think we're striving to get our indicators better, and that's being governed by the data. I think the genomics data can improve, and that will happen. I think the speed and timeliness has been asked as a specific question, and we're all aware of that. I think the super ambitious stuff, and I say super ambitious because I think we're already linking up to 6 or 7 data sets at the moment. I think primary care will be extremely important. At the moment, they're samples from particular primary care practices rather than all primary care practices, particularly when it comes to comorbidities and treatments that are sort of off the script as such, as opposed to something more serious. I think there are lots of people living with, grumbling chronic renal failure, type 2 diabetes, etc., which doesn't necessarily get picked up in the major comorbidities that you might have. With regards to the experience and the outcomes, we had a very successful national patient reported experience survey from the National Prostate Cancer Audit that was commissioned from one cycle. We did that in 2018, and what was fantastic, it was discriminatory in terms of people's experience, and when you ally that to functional outcomes, it provides even more compelling data. What we found is that when clinicians saw that there was an issue in the data set data, they believed it more when they saw the same data reflected in patient reported outcomes. So I think as we go forward, we really do need to translate that, and hopefully that will be reflected in the cancer plan. So thank you for reflecting that question, Tom. I'm going to move on to Nikki, if that's okay, just to see what your perspective is from the Royal College of Radiologists. You're part of our board. You've very much been integrated throughout with members across the audits. It'd be good to get your reflection, please.
So obviously the issue that really jumps out is the variation, and although we know that some of that may be warranted, most of it is unwarranted. So I'd feel the challenge is, what is the role of the RCR in reducing and hopefully eventually eliminating that unwarranted variation which we're seeing across all the diagnostic groups. Something that we are introducing is a group called the data implementation and audit leads. These are replacements for audit leads in individual centres, because we recognise that while the data gets to cancer alliances, actually those in the MDT, the majority of the clinical team actually treating patients at the coalface don't see the data. And yes, there's a lot of data available on Cancer Stats 2. They can attend webinars, but I think the majority don't. And it's really powerful to see your centre de-anonymised as well, your centre in comparison to other centres. And that really is a driver to get people to say, okay, what do we need? What do we need to do? So the dials will hopefully be the bridge between the data and the individual clinical teams, and vice versa. If they see that actually our data quality for our MDT is poor, there will be an incentive then to improve the quality of the data. But they're thinking about other ways that we can help to get the data out there to individuals. There's our networks, particularly heads of service, and heads of service normally get a presentation from our TDS, but hopefully we'll be able to start to introduce NATCAN data presentations as well to heads of service. And then there's all the other stuff that the RCR does, for example, the guidance. We do have frailty guidance. We published that in, well, I think it was 2022. I don't think the message has really got out there as far as it should looking at this. So that's something for me to take away and reflect on. And obviously the consensus statements are really important in reducing that helping to reduce that variation. The issue with our consensus statements is we go through a full detailed Delphi process, which is very thorough. But it takes 1 year to 2 years for one site, and we've done 2 breast cycles, and the breast team understandably would like to do a third, but we're saying, well, there's a queue. We would like, we haven't had a prostate consensus statement process. We haven't had OG. So we're looking at how can we abbreviate those consensus statements so we can be producing more quickly. And the final bit of the jigsaw I think we can have some impact on is that we are hoping to, well, we're looking at a process of MDT meeting as opposed to MDT teams reform, looking at, for example, streamlining, so making sure the patients, the complex patients, the patients with metastatic breast cancer don't sit at the end of 100 patients, some of whom probably didn't benefit from discussion in that MDT, but also thinking about how the MDT can again use the data, rather than the MDT meeting now is very much about getting through as many patients as possible. But actually we need to go back to the original intention of the MDT, and thinking about away days where we can look at our own data and think about how we can improve things. What are we doing? What are our pathways? What's the issue? Why are we an outlier? And really think about how that can be improved. So it's really thinking about the implementation piece, and I think that's where the RCR should play a role.
And thank you for all your support. I think having an audit or implementation lead at each trust, or at least looking to job plan, is the start of actually changing the culture on this moving forward. So thank you very much. We've got a couple of questions. I know we have a bit short of time, and I want to make sure I get through, speak to Martine, Dan and Danny. Martine, there's been a question around timeliness of data. Now we're obviously working with the rapid registration data and the sort of gold standard data, but is there work going on to try and improve the timeliness, or just curate that in a way that is ready to use for our performance assessment?
Absolutely, and there is. So as it's come up this morning as well, the timeliness question. So our gold standard, or the National Cancer Registration data set, is currently available around 18 months post-diagnosis. And part of that is due to the time it takes to curate multiple sources of data into a final sort of gold standard record for each patient, but some of it is also to do with the process of the data transfer and the volume of data and the complexity of data, which has been increasing over time. So cancer incidence has risen by 10% between 2012 and 2022. And has risen by 18% over that 10-year period, and it's getting increasingly more complicated with genomic data underpinning a lot of those diagnoses. So the rapid registration data set is one of our attempts to make data available at a much more timely interval. So that's available roughly 4 to 5 months post-diagnosis. It is entirely automated. There is no human input. It is based on the routine data that we get in. To my knowledge, it is also a world first. I don't think any other nation in the world has a rapid registration data set. And I think even the 18 months for the gold standard will be up there in terms of the fastest. But we are absolutely working on how we could increase this. So we're looking at ways and how we might be able to automate some of our curation in different ways. We are very gently exploring some AI type of approaches to help extract unstructured but rich clinical data, particularly from pathology reports or genomic data, to have that in a tabulated form that you could more easily use and integrate into your registration record. And certainly in NDRS, we have set ourselves a strategic priority to start registering cancer cases within 12 months of diagnosis in the next 2 years. Obviously, the background and the scenario in the healthcare landscape is impacting some of this, but that is what we're aiming towards. But in the meantime, some of the data assets, such as the RAPID, such as SACT and RTDS, they are available within a few months post-diagnosis. So there are some of the questions that you can answer with those RAPID data sets, but for some you might need the more complete data set, which requires that expert curation, and that takes that little bit longer.
Thank you, Martin. And I think most of all, people need to take responsibility. If people are looking at the data and saying why it's not quick enough or why it's missing, we all have a responsibility in our trust to ask who inputs the data, when is it inputted, and what can we do better. So I think we need that leadership at the trust as well. Dan, if I can come to you, just put your camera off, but if you're here, that was a signal.
It was just to avoid her on the sight of me massively sneezing in close up, Ajay.
So the question I had for you, obviously from NHS England, you very senior colleague there, is to really just put this into perspective in terms of what NHS England are doing at the coalface. We asked a similar question in the morning, but just if you could briefly just summarise what the support is at the sort of alliance and trust level for teams trying to look at their variation and understand what to do next.
Yes, absolutely. So actually what we have been trying to do in the cancer programme is make exactly the kind of links that Nikki was talking about earlier, and trying to make sure that actually the places that need to see the data the most certainly are having it put in front of them and are able to have those sort of facilitated discussions. And that's why, as I mentioned earlier, we set up a couple of years ago this treatment variation work stream within the cancer programme. What we do with that is we, once we've seen the annual reports from all of the audits, we work with the audit teams to identify one recommendation. One thing that we've learned over time is that the more focused you can be, if you're trying to do something at national scale, the more likely it is to have a chance of happening. So we do choose one recommendation from each of the audits. We say that needs to have regularly available data, and it needs to have some sort of, not necessarily a target, but at least a sort of a direction that we know people should be heading in. So it can't just be entirely sort of speculative or sort of for information. It has to have a sort of directional aspect to it. We identify those as priority recommendations from each of the audits, and we then make that part of the Cancer Alliance planning requirements for the year ahead. Cancer Alliances are funded to do work around this, and the expectation is that Cancer Alliances are then taking those recommendations and working with their clinical networks for the relevant cancers locally to get into a discussion about what might be causing that variation, exactly the kinds of things that we've been talking about today, whether that's a variation in clinical practice, in patient case mix, in the data quality that's being submitted. All of those are potential explanations, but ultimately we take the data at face value to start off with, and we work through the potential explanations. And if we think there's a clinical reason underpinning it, then we'll the idea is that is then the mechanism to identify that and make a change. I think so that's our program of work. I think my sort of our focus over the last year has been to try and really drill down onto the sort of lower quartile, or the providers that are below a clear benchmark. So we're trying to target this as much as possible. Now that we have 10 cancer audits, blanketing everyone feels like a lot to focus on potentially. So we do try and be as targeted as possible, and be a little bit flexible with that as well. But I would really urge all of you on the webinar today, and I know some people have had to leave because we're at time, to engage with your Cancer Alliance locally, to take the data at face value. Don't assume that the data quality is poor. You know, let's take that at face value, at least for the initial investigation, and try and understand what's driving that variation. You know, it's using the data that is going to ultimately drive up its quality. So I would encourage all of you to engage in that program and look at what we can do to try and drive out some of that variation, so that hopefully we see some of those funnel plots you know, concentrating around the middle over time.
Thanks very much, Dan. So Danny, just final comment to you, cardiothoracic surgeon working Health Quality Improvement Partnership. We're very good at pointing across the road and saying they have this machine, they have that treatment, they're using this technique, but where's our accountability with each other, or our system of governance or relationship building around quality and working together towards it is rarely mentioned in any of these high profile cancers. How do we move forward on that? You've only got a minute.
Right, okay, right. Well, the answer to this is there are local recommendations and national recommendations. We've had massive recommendations. We're awash with recommendations. If you've got 90 audits and you've got 10 recommendations coming out, yeah, just do the arithmetic, you know, who's going to take the answer, who's going to do what, and that's where we get lost sometimes. Now, from what I picked up today and this morning, there's one really important thing, and that is that wait between diagnosis being made and action. That is totally and utterly unacceptable, and I think that's more than any of us can actually handle. That needs to come from yourselves through me to National Quality Board. That's a kind of Daily Mail kind of thing, whereby you're waiting, having had the diagnosis made. Now, we've seen that in colorectal surgeons, and we don't want to beat colorectal surgeons up. We want to I bet you that's sitting around at the back of a lot of other areas as well. So I think that idea of having a diagnosis made and waiting is unacceptable. Can you imagine any of us having had a diagnosis like that, waiting 60 days? 6 days would be too much. So I think, Ajay, if you can drop me a line, and maybe if we could seek out and see are there any of the other cancers where this exact thing is happening, where patients having had the diagnosis made, is bad enough getting it, do the diagnosis, but having it made and waiting is totally unacceptable. So I would just like to end on that one, and we will take that to the Quality Board, and they will start to do something, and that's a national thing that needs to be done. That's not for each individual. Like, of each group can work on it, but there needs to be something coming in centrally on that. Thanks.
Thanks so much, Danny. We're just over time, 5 minutes over. Thank you so much to the panel for your detailed and granular discussion and actually optimism for the future. I do think we can improve this, and it has happened over the years with some of the more established audits so far. Thank you to all the speakers, both in the morning session and the afternoon session. All the webinar will be available online. For those who we've not responded to from the Q&A chat, we will get back to you. Just a few quick special thanks to Verity and Sagita, who are behind me scurrying away, which you haven't seen, but they've been fantastic, along with Julie, Aurelia and Faney and the rest of the team. So wish you a very good rest of the afternoon. Please do look at the data. Please do contact us if there are any queries, and let's look forward in terms of improving patient care for cancer in the NHS. Thank you very much.
Great, thanks. Great meeting. Thanks.
Thank you, everybody.
Thank you.